morning. I'm Dr. Julie Ingelfinger, and today I'm going to talk about the lifelong legacy of childhood kidney disease. Before I start, I will say I have no relevant financial disclosures. I'm a deputy editor, however, at the New England Journal of Medicine, and that is a paid position that may lead to intellectual bias. The objectives of my talk are several. I want to discuss the pathogenesis and putative mechanisms of the implications of childhood kidney disease, and I will divide that into perinatal programming or developmental origins of health and disease and acquired kidney disease. Then I want to discuss how to consider the identification and follow-up of at-risk persons and briefly to discuss possible therapy of at-risk persons. For in every adult there dwells the child that was, and in every child there lies the adult that will be. This applies to many things, and kidney disease is included, as you will see. If we think about the lifespan from late fetal life up until old age, and think about kidney disease, there are multiple things that determine what happens in the lifespan. For one thing, there are congenital kidney diseases or inherited disorders, which are genetic or programmed. There is also acquired kidney disease that occurs during the life course. There are contributions on the one hand of life challenges and on the other of nephron number. The number of nephrons or nephron endowment that we are born with has an increasing contribution over time. Additionally, through life, there are challenges. What about the kidney and cardiovascular legacy as determined by what happens in the perinatal period? Epidemiological studies published in the late 1980s and since replicated in many populations have shown an inverse relation between birth weight and the risk of cardiovascular disease, hypertension, and kidney dysfunction in adult life. This has been shown also in a variety of animal models. How did this come to light? The late David Barker and his colleagues in England had noticed in going over records that there was high infant mortality in the first decade of the 20th century. And later, as people born in that time became older, there was a high incidence of death due to coronary heart disease in the cohort, looked at some 60 to 70 years later. This was in large part due to meticulous nurse midwife records in Herefordshire, where these nurses were what we'd call a bit OCD. They wrote down birth weight, placental weight, and made some comments so that there were detailed records, although they were the records typical of over 100 years ago. What these showed was that in term infants, there is a different birth weight. Some people are on the heavy side and others on the light side. But when one looked at, in this case, men born in Herefordshire, those who weighed less, 5.5 pounds or less, had more systolic hypertension than in other groups. And this was essentially a dose response curve related to weight. Another early study became possible from records kept during a hunger winter in World War II when the Nazis starved people in the Netherlands. And there was an area around Amsterdam where people had just 400 to 800 calories a day. Of course, some of these people were pregnant women. And what was found was late on, these women had children who had a higher incidence of cardiovascular and renal complications. So what happens in the perinatal period is now considered a surrogate for adverse perinatal conditions. Your weight at birth reflects to some extent not just your genetics, but also what happened in utero, and experimental studies in animal models confirm this. Additionally, what happens after birth is very important in the early phases of life, and this influences later outcomes for the affected children. Indeed, the Barker hypothesis, that is, altered embryonic and fetal development resulting in low birth weight and predisposition for adult disease, can involve multiple organs. In the area of our interest, to altered kidney development. And low birth weight does correlate with reduced nephron numbers or nephron endowment. Brenner and his group concomitantly in the 1980s were thinking about nephron number, that a reduction in filtration surface area led to changes in sodium handling, changes in filtration, and indeed hyperfiltration, which also led to hypertension and kidney disease. Combining these two hypotheses has led to the idea, shown many times over, that what happens in the perinatal period and afterwards is very important to our susceptibility to kidney disease and hypertension and chronic kidney disease, even end-stage kidney disease. So, insults in the perinatal period affect multiple areas of the body and program us to future health or disease. I'll give a few examples. If we look at the preterm person and look at their hearts in young adult life, are these different from those who didn't have a problem? Blue means a preterm child as a young adult. Green is a term child as a young adult. And the AT means an at-term person who was 10 years older than the cohort. So what you can see in terms of left ventricular mass is that it is significantly higher in those who were preterm at birth. And if we plot left ventricular mass and brachial pulse pressure and divide people into those at term, 10 years older, and those who were young adults born at term or preterms as young adults, you can see that these values are higher in the preterm, which confers increased susceptibility to cardiac disease over time. Additionally, if one looks at ejection fraction, it's the same. It's lower, the same principle. It is lower in those who were preterm than at term or at term looked at even 10 years later. So what about critical periods in human gestation, and what about the kidney? We know that the heart develops even earlier than the kidney. It starts very early in embryologic development, whereas the kidneys developed later. And as this audience knows, all the nephrons you'll ever have, according to current thinking, will have been formed by 36 weeks of gestation. It is very important to know that DNA sequences, i.e. our genetics, does impinge on how we develop during intrauterine life. There are maternal factors and paternal factors, not all of them genetic, but some genetic, that lead to how we are exposed to things. And there are certainly environmental factors, such as those I noted earlier. All of this exposes the fetus to programming, and fortunately, fetuses have developmental plasticity. We now know that epigenetic marks and changes that alter the conformation of DNA but don't change sequences, are very important. We know that epigenetic changes plus cell division and early life experiences can lead to long-term effects, and the mother's status during pregnancy is important. We also know that epigenetic changes plus germ cell programming can lead to transgenerational effects. So, looking at developmental origins and changes in the heart and kidney, we know that epigenetic changes may be very important. These will inform proteomic changes, what happens to the proteins we produce, what happens to the metabolome or the small molecules we produce. But there are other external changes and exposures, and the microbiome to which we are exposed at birth also contributes greatly. So for an example, there can be a variety of in utero stressors. Some of these are from the mother, suboptimal nutrition, for example, or hypernutrition. There can be models of this, such as uterine artery ligation, that lead to changes, hypoxia, increase in glucocorticoids, psychological stressors, maternal diabetes, alcohol intake. All of that will change your epigenome by methylating DNA, making histone modifications, making changes through non-coding RNAs. That will affect a variety of molecular pathways. For example, and I could have put in other ones, mitochondrial function may change, leading to oxidative stress, to inflammatory substances and a variety of cytokines, to, in particular, changes in vasoactive peptides and hormones. These will impact vascular capacity that develops and nephron number. This can change if there's injury, can lead to aberrant physiology and aberrant vascular growth, and make people more susceptible to disease later in life. For example, what about maternal obesity, which is increasing and is rampant in many areas? Excessive lipolysis in such mothers occurs, and this increases free fatty acids and reactive oxygen species and leads to inflammation. This impacts the fetus and has impacts on the growing heart, kidney, and on chromatin. So epigenetic changes may perpetuate what ends up as inflammation, which will lead to a predisposition to endothelial dysfunction on the one hand, to microalbuminuria over time, to changes after birth, and ultimately a propensity to increase blood pressure and to cardiorenal disease. There are clinical implications of developmental origins. It is possible to know which children are at risk by keeping good records. Such young children should have minimal exposure to nephrotoxins if possible, should be encouraged to have a healthy lifestyle, and should most of all be monitored. Later in life, they should still be monitored and specific medical risks avoided. For example, if you're interested in maintaining excellent kidney function, some people should not be kidney donors, among them people who were small for gestational age. But there are at-risk children who are not identified. So I would say, as physicians and as people transitioning young people to internal medicine care, a high index of suspicion should be transferred. We need, as a group, to think about this for our patients. Well, what about kidney disease that's acquired during childhood? What difference does that make? Long ago, when I was a fellow, we were taught that if somebody recovered from acute kidney injury, they were going to be just fine. That is, in fact, what I was encouraged to tell parents, but now we know that is not always the case. So I'm going to go over several studies. One is, what about people with a history of childhood kidney disease and their risk of adult end-stage kidney disease? This study by Calderon-Margolet et al. Should make us worry. What you see here are 4 panels, and you can see differences, and I'm going to focus on 2 of these. These investigators looked at adults who had as a child evidence of congenital anomalies of the kidney and urinary tract, Acute, had episodes of pyelonephritis or had glomerular disease, and they then lumped all these together to look at one of these, Acute. What you can see is a history of congenital anomalies of the kidney and urinary tract increase the likelihood of kidney injury or disease. If we look at all childhood kidney disease and unresolved, I'll start again. If we look at all children who have had kidney disease and then are adults and see, is it resolved or not, as compared to no history of kidney disease, what is found? What you can see here is those whose kidney disease did not fully resolve have a far higher frequency and risk of end-stage disease. If they recovered, or the condition is only mild or had no history of kidney disease, the risk at age 40 is far less. If we look at this another way, what about the burden of kidney disease in Indigenous children in Australia and New Zealand? One thing that has been noted is that among Aboriginal peoples in Australia and New Zealand, nephron number is lower as determined post-mortem. But what about the frequency of kidney disease in Indigenous children as compared to those who are not? What you can see here is that if you look at non-Indigenous people as children from New Zealand and Australia, that if you look at them across the life course, they don't have much end-stage kidney failure. But if you look at Indigenous persons from Australia, from New Zealand, look at Maori people, or look at New Zealand Pacific Islanders, their frequency peaking in midlife is far higher. If one plots this another way, looking at the ratio of renal failure, that is comparing Australia Indigenous to non-Indigenous Maoris or Islanders, what you can see is that in every case, at every age, and more from midlife onward, there is more kidney failure, suggesting here that perhaps it is nephron endowment that's important, as well as environment. To take another topic, if a child has cancer, he or she is very likely to be exposed to nephrotoxins in the course of therapy, as well as other issues. So in this particular study, what the authors did was compare many people with no history of cancer to those who'd had a benign tumor to those who'd had a malignant tumor. And what they looked at was the age at follow-up, and what did they find? Well, what you can see is those who'd had no tumor, which is the dotted line, or had benign tumors, had, as they aged, a far smaller incidence of end-stage kidney disease as compared to those who'd had a malignancy. If we look at another big category, what about acute kidney injury, AKI? There are criteria both for children from KDIGO and modified for the newborn period. And I'm not going to go through this whole slide, as I think this audience knows these data. Historically, renal failure in the NICU has been associated with poor growth of the kidneys, as well as a decrease in GFR and renal tubular dysfunction. This urogram with rather small kidneys is at age 5 in a little girl who had newborn acute kidney failure secondary to birth asphyxia. The length of her right kidney is 5 standard deviations below the mean of normal, and the left kidney also is small. So the reduction in mass here was presumed in this study from 1987, so 33 years ago, as the result of that perinatal insult. hints from historical data from a place where much kidney disease occurred in the form of acute hemolytic uremic syndrome. That is Argentina, where there are tons of cattle and people love their meat. There have been many outbreaks of HUS there due to sugar toxin. What they did in this study, and it's not a large study, N is 118, they looked at proteinuria on the top and glomerular filtration on the bottom, and they divided the patients into group 1, those who recovered completely, and to end-stage disease, not very many, just 4 out of 118. But if instead of looking at this, you look at whether they had a sign early, and here it's at 1 year, those who had no proteinuria, 3/4 of them had complete recovery, and nobody in group 4 was here. If you look at those who did have proteinuria at 1 year post-HUS, it's almost the reverse. Half of them had low creatinine clearance and or proteinuria at that time. And if you look at it as what was the glomerular filtration rate 1 year after HUS, you also see that if there was a normal GFR 1 year later, it was only roughly a third who had a decrease in kidney function or heavy proteinuria, whereas those who did have a low GFR, almost half of them had an effect. So one can see signs early, but there are hints that AKI in childhood does not signify complete recovery. A similar and also small study of diarrheal HUS in Norway found indeed that there were effects long term, and this has now been shown many times. We know that by the time we got into the 21st century, more children survived an acute episode of acute kidney injury. By discharge, 68% had normal kidney function, most had, of the rest had improved function, and a minority had continued kidney failure, and 5% in this retrospective study progressed to end-stage disease. But what is the very long-term outcome? Childhood is the minority of life these days. One systematic review looked at a lot of articles published from 1985 to 2003. Of those, there were only 10 studies that were good to look at, 10 cohort studies that included 346 children with a mean follow-up that was medium length, just 6.5 years. But the cumulative incidence rate per 100 patient years in that group suggested that proteinuria, hypertension, diminished glomerular filtration rate, and end-stage disease, as well as mortality, were higher. They concluded that acute kidney injury is associated with a high risk of long-term renal outcomes that are adverse, and that these may have implications for care after an episode of AKI in children, and obviously said future prospective studies were needed. One such study that has been published since the millennium is by David Ashkenazi and colleagues. What they found was that they had 425 patients identified, and what you can see here in that kind of study is that if you look at the black, meaning those with abnormal results, if you look at the survivors, more have a higher albumin creatinine ratio, more have a low GFR, and if you measure GFR, some of these people have hyperfiltration, which puts them at risk. So In all, to understand the burden of acute kidney injury, it's critical to describe the incidence and impact of it outside of the ICU in general populations, and to look at those with chronic medical conditions. In one study by McGregor, there were over 13,900 general pediatric admissions at a tertiary care hospital, and they showed that acute kidney injury was present in at least 5% of admissions. And it's important to think about acute kidney injury extending to other groups, such as children who have other chronic problems, such as diabetes and sickle cell disease. The evidence continues that acute kidney injury is common in newborns and children, and poor outcomes do occur, and not uncommonly. A couple of years ago, a study appeared as a review article and simply showed a diagram of acute kidney injury interacting with chronic kidney disease. What you can see here is different risk factors and outcomes. But what was missing at that time is this: nephron endowment, early life events, and childhood kidney disease are indeed risk factors, in my view, and that of now many others. So finally, what do we do to identify and follow up at-risk persons? And can we treat them? Well, there are few data about actual interventions, and most of them have failed. Some data during acute care are listed here in terms of those things studied. Aminophylline during acute illness to prevent AKI was a study that was stopped early and not for success. Sodium bicarb during cardiac surgery in children is still ongoing. And there have been studies about balanced salt solutions versus normal saline in children with sepsis, not very protective. Hydroxyethyl starch has been popular during sepsis and surgery. It's not clear that that helps. Dexmedetomidine during cardiac surgery also has been important to study, but it isn't proven to help. Or phenoldipan during cardiac surgery. So studies are being done and thought about, but more studies are needed. And there are candidate interventions. These include antifibrotics, immunosuppressive agents, glucocorticoids, omega-3 fatty acids, dietary interventions, and targeting pathways that biomarkers suggest. Studies that are still to be created and thought about. So if one thinks about childhood risk factors for chronic kidney disease, there are many to think about and to compare to adult disease. This simply includes leading etiologies of chronic kidney disease, but doesn't really talk about them as risk factors. We know how common diabetes, glomerular disease, hypertension, ADPKD, and other cystic diseases are, leading to CKD in adults, and that congenital anomalies are important in children as well as the other things listed here: glomerular disease, ciliopathy, HUS, ischemic kidney failure. But what we don't think about enough is that genetic factors are very important, but that may involve a minority of people, but that perinatal factors are very important, and these may include epigenetics. And then there are the major childhood kidney diseases I mentioned, and things that are not to do with kidney disease initially necessarily, but impact it and cause it. And there are lifestyle factors. So all in all, has anybody thought about this in an organized way? 3.5 years ago, a group came together to discuss and write about low birth weight and nephron number and things that impact risk of long-term kidney disease. They had some recommendations for action, and I'll just go over these. They are simple, and we should all do them. Number one is record the gestational age and birth weight in every child. Identify those who are growth restricted or low birth weight. And if a child has a gestational age, that means they're premature or low birth weight, also document this. And importantly, such children should be monitored regularly for the presence of elevated blood pressure, excessive weight gain, albuminuria, and hyperglycemia over time and really throughout life. One can become aware of these issues during infancy and think about what to do. Certainly, some of the at-risk people develop newborn AKI, and in any event, avoiding the use of nephrotoxins is important, and monitoring dose of medications, kidney function, and fluid balance is important, and monitoring it. And put down the early warning flags in the electronic medical record. After the newborn period, again, document course, optimize lifestyle, and also monitor parents who may have had problems, mothers who've had preeclampsia or gestational diabetes, and educate patients and ourselves. And as a child grows towards adulthood, educate them concerning the need for long-term follow-up and sharing this kind of legacy with transition to adult care. Finally, what does all of this mean? The group that got together and talked about what to do had a very nice use of some data that by now is a decade old. But this is thinking about everybody born in 2010. If you think about it, there were 77 million people born who were term and were appropriate for gestational age and size. There were 19 million who were small for gestational age but term. There were 6 million and change who were premature and appropriate size for gestational age. There were term babies who were extremely small for gestational age. There were preterm babies who were appropriately sized for gestational age, but were of low birth weight, and preterms of very low birth weight. If you look at those at risk, what this turns out to be is 36% of people born in 2010 are at risk epidemiologically anyway, and this can translate into the loss of much human capital, can lead to much disease, and cost a lot. Marking these people for needing monitoring and care is very important and something we can do currently. Thus, going back to where we started, we know that there's congenital kidney disease, acquired kidney disease, and a contribution of nephron number, increasingly important over the life course, and the contribution of life challenges. So I would propose that thinking about kidneys from fetal life till we walk off the earth is terribly important and could save much in terms of cost and improve a lot what our contributions are in the world as humans. Thank you very much. I look forward to your questions in the panel discussion, and it is also fine to send me questions via email.